Hello and welcome to Filibusters in Fine Print, where AMGA's public policy team gives you the insider view on healthcare regulations and legislation. Thanks so much for joining us for the latest from Washington, D.C.
Good morning and welcome to Filibuster in Fine Print, AMGA's public policy podcast. Glad to have you all here. As always, we're here with AMGA's expert panel.
Is that a question?
I guess I did question it.
Are we happy to be here?
Well, y'all get paid to be here, so I hope you're happy. That's sort of where we are these days. Let's introduce ourselves. So the last podcast, I asked for final thoughts, and Miss Latney did mention that she did not have the last thoughts. So will you start our podcast and say who you are and give us your, how angry were you that you didn't get a last thought?
Well, I am the baby girl of my family, so I'm used to being lavished with attention. And I'm not used to having siblings, so this is very odd for me. I'm Lauren Latney. I'm Director of Government Relations here at AMGA.
And we're glad you're here.
Thank you so much.
And the blanket that AMGA provides.
Yes.
We're wearing gravity blankets right now?
Blanket.
Yeah. Wait, that's it.
Don't shade.
More like threadbare.
Nice. Jamie Miller, Senior Director of Government Relations here at AMGA.
Fantastic.
Alicia Sawyer, Government Relations Assistant.
Hi, I'm Daryl Drevna, Senior Director of Regulatory Affairs at AMGA.
Fantastic. And I am Chet Speed, your host. We usually ask a question to start these things, but I just wanted to point out that I think the podcast is going to the team's heads. Let's see. Miss Sawyer here wants her own microphone.
Is that too much to ask?
Well, coming to Mike I. Mike I took my microphone away, by the way. And Mr. Largely true. And Mr. Drevna insists on his own headphones so he can actually tune all of us out.
Just to play devil's advocate, I think someone in the room asked for warm chocolate chip cookies before they got here as well. I don't know who that would have been.
I don't know what you're talking about. But just don't look at me in the eyes, okay? And don't talk to me directly. Talk to our peeps. All right. Well, today we're going to talk about some of the new issues that AMGA has put in its portfolio of issues. There's, I think, 3 or 4 of them, and they're important, and they're all member requested, which is why we're pursuing them so strongly. We have GME is a new issue for us.
Woo woo.
We have the enhanced PTC extension. We have Medicaid, which we talked about a lot. So we thought we'd talk about those, let the members know what we're doing on these issues and what's happening with them right now. And then we're going to talk about our old value agenda, not old, but things that we've been pursuing for a long time. And we'll give you an update on that as well. So let's talk about GME.
Let's do it. I love talking about academic medical centers. I love talking about training doctors because we are not going to have enough of them by 2035. I think we're going to be at absence of like 140,000 or more, which means that we have not done as a country and through Congress enough to expand our doctors. Mm-hmm. Now, the reason why is because in the either late 80s or early 90s, there was a report that came out. I can't remember which GAO report or something that said, we're going to have a surplus of doctors. That's too many doctors. And so Congress is like, whoa, we need to sort of slow this down. Let's slow down the rate of how much we're paying because Medicare, if you don't know, pays for doctors to be trained. It's under Medicare Part A. And so they're like, we as a government don't want to have so much spending on this. And so we're kind of going to curtail the amount that we have. So they kind of created a slot system. And so right now there are, it's called graduate medical education because of the fact that you're training through hospitals, but there's a limited number of slots, right? So every year you might have residents that don't match. And so they kind of either go into research, they have to reapply. And so when you're looking at what the future of healthcare is, people are not getting younger, they're getting older every day. And so there's a fear that there's not going to be enough doctors to treat Medicare patients. And so what GME is focused on and what we're focused on with our coalition partners is increasing the number of slots. And the reason why is because if we don't start increasing them now, it's going to be too late and there's going to be sort of a backpile. So right now there's some legislation that will be reintroduced in the Senate and the House that would it's called the Residency Act, which basically would expand the amount of residency slots so that we have more people coming in and more opportunities. It's a kind of uphill battle. I think during the ACA they expanded. I can't remember the number of slots, but they did expand a number of slots, but not nearly the 1,400 that they really want. And so we are trying to make sure that increases. It's an uphill battle because it's also very expensive to train doctors, is what I've been told.
Okay.
Because they got to learn things. You're also thinking about sort of the productivity kind of goes down if you're working in a hospital because you're training new people. If you haven't watched The Pit yet.
I knew it.
I was waiting for it to come.
There you go.
The
This
pits.
is what you should do because it starts with residents as they start on their first day of training in the ER. But, I mean, it's an important issue because we just don't have enough. And even if we're increasing nursing, we're increasing all that, you're still going to want to have a strong provider base. And so that is one of the things that our PPC, our Public Policy Committee, has recommended to us. And that's one of the things I'm really excited to chat more about on the Hill.
And Lauren, on the GME space, are there things that we need to be worried about? Potential cuts and things like that we've been hearing about on the Hill?
So there was initially some concern under reconciliation that they might have cuts to GME slots. From what has been shown right now, that is not an issue. Of course, this is, reconciliation is a rapidly evolving issue. And so that might be, but it's certainly not something that is of absolutely we're terrified about this.
Those
right now.
indirect payments, right?
Yeah, indirect payments are sometimes the payments that go in because of the fact that things kind of slow down when you're training a doctor.
Yeah.
But I think those are always floating around, but they never go anywhere. So we want to make sure that we continue to focus on making sure those things don't get cut.
Okay, so we want to increase slots for GME.
Yeah.
And if someone's going to be on Medicare in less than 5 years, I completely endorse increased GME slots. And also, so what channel is Pitt on for our viewers?
It's on HBO. They have dropped Max, thank God. So now it's back on traditional HBO, and it's called The Pit. It's got Noah Wiley in it. It's so good. Mike I, our producer, is nodding because I talked about it so much that he started watching. But yeah, I think it's a really great understanding of what the issue is and why it's important.
And it's in Pittsburgh, so we can talk about that.
And here we go.
Yeah.
There's a dog in it named Crosby.
Is there?
Oh yeah.
All right.
Sid.
Oh, Pitt's out. As a Washington Capitals fan, that's an anthem.
Down
So-
0-1 right now.
Oh, they do yeah, they're in the playoffs though. All right.
That's about Sports Talk 990.
Moving on. Okay, and who's handling enhanced PTC extension policies?
So that's me, Jamie. So the reason this deals with healthcare coverage, the reason we're talking about it in the first place is there's a policy that's going to expire at the end of this year. To give a little background, the Affordable Care Act's goal in 2009 was to make sure that these 30 million plus people who didn't have healthcare coverage got healthcare coverage. So we did Medicaid expansion in certain states. We did premium tax credits to allow people who were above the Medicaid qualifying to get these access to these premium tax credits. But during the pandemic, the Biden administration enhanced the premium tax credits and provided more people. About 3.2 million people were allowed to get that. That started in 2021. The problem is that this tax subsidy will expire at the end of the year. It is a Democrat idea for the most part, and if you extend it, it'll cost $275 billion over 10 years. We are following this and pushing for the extension because these 3.2 million people are people and beneficiaries of our systems and medical groups. And so this is about patients getting access to care. So we will continue to advocate for the continuation of the enhanced premium tax credit.
Okay, and so that extension from a timing perspective will likely be post-reconciliation. Is that right?
Correct.
This will
December.
be a government funding bill issue at September 30th. Is that
Or Christmas.
or Christmas, right?
Yeah.
Or
It's
March,
yeah,
which is the
what-
current thing is to do these things in March now.
It expires the same time a lot of the Trump tax cuts expire as well.
Okay. All right. Well, that's outstanding. Another issue that we took on this year is Medicaid. We've talked about that a lot, but Daryl, why don't you give us an update on Medicaid.
Sure. So it's a very fluid situation, as the rest of the team has talked about. But essentially, Republicans are looking to restructure how Medicaid is funded at the federal level, and ultimately they're looking to cut between $550 and $800 billion from the program, which AMGA and its members are opposed to. Now, how they're going to do this is really much up in the air. You can do things like changes to provider taxes at the state level. You can change the FMAP either for the expansion population or the population as a whole. You can do per capita caps either for the expansion population or for the program as a whole. So while the policies are still getting fleshed out, ultimately they're looking to take money out of the Medicaid system, which our members are opposed to, because it would really, I've heard members say this is an existential crisis for them if they take that much funding out of the revenue that's flowing into their systems that provide the ability for them to, frankly, keep the doors open. So we are pushing back very hard on any cuts to the Medicaid program.
And so you all are busy. We've added GME, we've added enhanced PTC extension policies, we have Medicaid, and some other matters, but we still have our tried and true issues that we've always lobbied for the past several years. I believe we call that our value agenda. Is that right? So as we fight, or as we lobby on Medicaid and other issues, let's talk about our value agenda and what we're doing there and what we're pushing.
Yeah, so this has been a longstanding AMGA concern and priority, is helping members in transitioning the healthcare system towards one that's based in value or high value care. And one of the premium programs or mechanisms to do that is through the Medicare Shared Savings Program, or ACO. So really what our main priority there on the legislative side is extending the APM bonus. You recall MACRA included a 5% bonus that's expiring. But we've heard from the members, it's not just an incentive to get into this program. The funding that comes through the 5% bonus is really critical to maintaining the infrastructure, the staffing, and everything that goes into running an ACO. So that's one of our big ticket items.
Okay, so still pushing on ACOs. That's great, because the MSSP program was actually, the legislation was drafted by AMGA in 2010. So one of our most significant policy priorities. Medicare Part B cuts. What's going on there?
Yeah, so Medicare cuts is something that we have had an active campaign for the past 5 years on the Part B cuts. Every time it's now an annual campaign. This was an issue, I think, several years ago that we thought might be solved with the SGR, but now Medicare, the Part B cut is made whole at times. Sometimes it's a partial fix, but we're never fully whole because we keep facing a year after year of cut. And so this past year we had a 2.85% cut to the Medicare Part B conversion factor. It is yet to be addressed. It's an issue we're still actively lobbying on, but it affects the Part B reimbursement rate.
Yeah, indeed. And we have heard rumors, and only rumors, about maybe a Part B fix is including reconciliation, but I think that's a rumor of war and nothing more. Is that right?
I've never heard a rumor of war. I feel like they want to have some sort of thing to dangle in front of providers to not talk about Medicaid, and but I think that conversation is getting softer and softer instead of louder and louder.
Okay, all right, fair enough. From our most popular lobbyist, Lorna. And what else we got, Alicia?
We're also actively lobbying on telehealth all the time. We love telehealth.
Who doesn't?
I mean, seriously. And so we're lobbying on some of the pandemic era telehealth flexibilities that have been extended for the past few years now. And those are the originating site and geographic requirements. And so that allows providers and patients to receive telehealth outside of a physician practice in their own homes and, wherever you can access the internet to receive telehealth.
All right. Yeah, that needs to be extended, doesn't it?
Yes, it is It is expiring in September.
Okay. So one of our priorities is to make sure that the expiring telehealth regulations are waived beyond September 30th.
Absolutely.
Right? And we're doing that as we speak, I have no doubt. MA's popular.
Yeah,
Daryl?
always. It's actually more than half the population of Medicare population is enrolled in a Medicare Advantage plan, so it's incredibly popular with beneficiaries and providers because it provides like a stable funding platform or reimbursement platform for our providers to do what they do best, and that's provide high quality care. That said, there are a lot of reforms that we're pushing for in the program. First one that comes to mind is prior authorization. CMS a few years ago changed how plans need to respond to prior authorization requests. We don't think they went far enough, and effectively, essentially, it's the time frame that is really causing headaches for our providers and patients. So we're looking to have the use of prior authorization reduced to the extent possible, because if you look at the data, about 80% of prior auth requests that are appealed ultimately are approved. So it's essentially a delaying system that we need to address. Other parts of Medicare Advantage is the risk adjustment and how coding is done. And this is this transition from version 24 to version 28 in the CMS HCC model, which I could talk about length on. I know you all want to hear me talk about risk adjustment and coding in Medicare Advantage.
We got another 30 minutes to go, so
Probably,
fill in that time.
First in a several part series. But really what they did is they took a number of codes out of the system, and it's kind of a backdoor cut to the program. So those same patients are going to have the same conditions, whether or not you code them or not. But it's going to change how you ultimately get reimbursed. So that's something we're pushing on in the Medicare Advantage space as well.
Fantastic. CCM?
Right, chronic care management. And this is an interesting thing. So this is the CMS a couple years ago in Congress. They created a code to reimburse clinicians for some of the behind-the-scene work they do in managing chronic disease. Right, it's a really interesting way to ensure you've got a team-based approach to managing chronic disease, which costs billions of dollars in the healthcare system. Unfortunately, the way it is structured, patients receive a co-insurance or a co-payment if your clinical team is doing this. They don't understand why they're getting billed for not a non-face-to-face visit. So what the legislation we're pushing would remove that cost sharing requirement from this code, so providers could bill this code, get reimbursed for the work they're doing without triggering this confusing and unclear cost sharing requirement for patients.
Okay, and enhancing care coordination for Medicare beneficiaries.
Right.
Oh, that's great.
Yeah.
One of I think our final value-based agenda issue is access to claims data.
Yeah, and it's perfect to pick up on the note of enhancing coordinating care for Medicare patients, because that's exactly what we're trying to do by lobbying on behalf of access to claims data. And so providers don't have access to all of the claims data that the payers have of what services patients have received. And so sometimes patients receive duplicate services, and that gets expensive. And so we want to make sure that providers have access to all of the information available so that they can provide the best coordinated care to patients.
Fantastic. I do believe we had legislation that would have required commercial payers to provide claims data to providers through an API. I am 60, so I have no idea what an API is. I do believe Lauren and Alicia know it because they're younger.
An API is just like a lovely cover for all the data that's behind the scenes. So like Netflix is an API.
Is it?
Yeah.
Oh.
Yeah.
Yay. Thank you.
Yeah, now you can tell everyone you know all about API.
Yes.
API. That's an applied platform interface.
Yes, there you go.
Uh-huh. So, well, fantastic. Well, look, we have to end on Netflix, don't we?
I mean, I'm more of an HBO girl, but sure.
Okay. And Netflix saved us during COVID. That's all I know.
That's true. That is true.
Tiger King.
Love is Blind.
And Ballroom. What was it?
Baby Ballroom. Yeah.
Oh, we watched that 165 days straight.
Wow.
Yes.
I'm sure like you're at the top 0.1%.
I believe we actually had the host did a Zoom with us for Barkley's birthday.
Oh, that's pretty cool.
So yeah. Anyway, okay. My guy is saying that's enough. Same guy took away my microphone. All right. Final thoughts, Miss Latney.
I think it's really exciting that we're doing all these additional issues. I think it keeps us fresh, and it also allows us to kind of make connections with offices and other coalitions that we may have not been able to do before. So I'm excited about this.
Outstanding. Jamie.
Yeah, and these are a guideline of the issues we're doing. Like Lauren and I, we're going to the Hill. We're talking about a lot of different things. So if you're an AMGA member and there are issues that concern you, this is a very organic process. So please bring it up to us. I mean, and the way the access to claims data happened was because of the survey results. The way CCM happened was because a member complained to us years ago about this. So like communicating to us is really helpful, and we're very flexible.
Great point. Alicia.
Yeah, I love the way that these new issues are engaging members with us and members that haven't previously been super engaged with us. And in the next few weeks, you'll be able to find these issue briefs for our new issues on the AMGA website.
Great. Carol.
Yeah, no, I just would reiterate what the rest of the team said. Like, bring these issues to us. Bring your stories, your casework, or the pain points you're having with any of these issues, so we can really articulate what that problem is, either to the Hill or to the regulators over at CMS.
All right. Well, thank you very much. That's it from AMGA Today and You Cook.
Thanks for joining us for Filibusters in Fine Print. This podcast was brought to you by AMGA. For more information about AMGA's advocacy efforts, visit amga.org/advocacy.